Welcome, everyone, to ERMP and Beyond, where the heartbeat of clinical medicine resonates with every case we explore. We invite you to embark on a journey through the intricate world of medical puzzles. Together, we'll dissect, analyze, and solve the enigma that awaits us. Prepare to be challenged, enlightened, and inspired as we delve into the essence of today's medical marvel. Let's begin our quest for knowledge and understanding without further ado. A 40-year-old female patient came to the emergency department with a complaint of 2 episodes of bloody vomiting of 3 hours duration, which was about 3 Arabic coffee cups on each episode. She also has history of black tarry stool. On examination, the blood pressure is 90 by 50 mm mercury, pulse rate is 120 beats per minute, and hemoglobin concentration is 10 grams per deciliter. What is the best initial management of this patient? A. Endoscopy and band ligation. B. Resuscitate with intravenous fluid. C. Blood transfusion. D. Intravenous proton pump inhibitor. Welcome back again. Today, we will see a critical topic in emergency medicine, the steps in the management of gastrointestinal bleeding, focusing on the upper GI bleeding. This condition can be life-threatening, so understanding its management is crucial for any healthcare professional. The patient's presentation of bloody vomiting and a history of black tarry stools, referred to as melena, are indicative of upper gastrointestinal bleeding. The low blood pressure and elevated pulse rate suggest significant blood loss leading to hypovolemia that eventually will lead to hypovolemic shock. The hemoglobin level indicates mild anemia, likely due to the bleeding. Let's start by exploring the common causes of upper GI bleeding. Peptic ulcers are the most prevalent, accounting for half of the cases. These ulcers are often the result of an infection with Helicobacter pylori or the use of nonsteroidal anti-inflammatory drugs. Other significant causes include esophageal varices, which are typically associated with liver cirrhosis, as well as Mallory-Weiss tears, and, though less common, malignancies. Now, onto the signs and symptoms. It's vital to look for the red flags that indicate severe conditions such as hypovolemia or hemorrhagic shock. These red flags necessitate immediate fluid resuscitation and include symptoms like syncope, hypotension, pallor, diaphoresis, tachycardia, and oliguria. Does our patient have any of the red flags? Of course she has. Tachycardia of 120 beats, and the hypotension. Moving on to initial management strategies. The first step is to stabilize the patient's hemodynamics with aggressive fluid resuscitation using isotonic crystalloids. In cases of severe anemia or ongoing blood loss, blood transfusions may be necessary. Additionally, administering proton pump inhibitors is essential to reduce gastric acid production, which can exacerbate the bleeding. For intravenous fluid resuscitation, it's important to establish large-bore intravenous access for rapid fluid administration. Isotonic crystalloid solutions are used to restore intravascular volume and improve hemodynamics. If crystalloid therapy is insufficient, blood products such as packed red blood cells and fresh frozen plasma may be administered. Diagnostic investigation is also key. Upper GI endoscopy, such as esophagogastroduodenoscopy, allows for direct visualization of the upper GI tract and the source of bleeding, facilitating targeted management. Now, let's apply this knowledge to manage our patient in the case. What would be the initial step in managing this patient? The best initial management for this patient would be option B, resuscitation with intravenous fluids. Option A, endoscopy and band ligation, is an important diagnostic and potential therapeutic procedure for GI bleeding. However, it is not the first step in management before the patient is hemodynamically stable. Endoscopy can identify the source of bleeding and allow for interventions like band ligation if varices are the cause, but it should follow resuscitation. Option B, resuscitation with intravenous fluids, is the best initial management step. This is because the patient is likely hypovolemic due to the blood loss, as indicated by her tachycardia and hypotension. Intravenous fluids will help to restore intravascular volume, stabilize blood pressure, and improve organ perfusion. Option C, blood transfusion, may be necessary if the patient continues to show signs of severe anemia and ongoing blood loss after initial fluid resuscitation. The decision to transfuse should be based on the patient's response to fluid resuscitation and continuous assessment, including repeated hemoglobin measurements and monitoring of vital signs and hemoglobin levels to assess ongoing blood loss. Option D, administering an intravenous proton pump inhibitor, is an important adjunctive treatment in the management of upper gastrointestinal bleeding. Proton pump inhibitors help to reduce gastric acid secretion, stabilize blood clots, and promote healing of the gastric mucosa. However, this is not the first-line treatment in a hemodynamically unstable patient. As we conclude today's topic, I want to express my heartfelt gratitude for your participation. I hope this lecture enhances your understanding and management of upper gastrointestinal bleeding. Your engagement is crucial, so please, subscribe to stay updated on future sessions. Your likes and comments not only enrich our case discussions, but also help us reach a broader audience through the YouTube algorithm. Thank you once again for your active involvement in today's journey of knowledge.